Assalamu alaikum wa rahmatullah. Good morning, everyone. I'm going to share with you two cases that will hopefully set the stage for subsequent discussion. The first one was an elderly with non-valvular AF and acute coronary syndrome, 78, who presented initially to another hospital with signs of heart failure and ACS. He has a past history of stroke and chronic atrial fibrillation for which he was not on any anticoagulants. When he came to us, he already had signs of heart failure and already had signs of residual signs of his previous stroke. He was in atrial fibrillation, and his echo shows previous an old inferior MI and recent distal LAD territory problems. He has triple vessel disease. He has an occluded right. He's got a tight stenosis in his mid-LAD and another ostial OM lesion. He has biomarkers for non-STEMI, positive troponin. He has signs of heart failure with elevated natriuretic peptides as well. So he was an acute non-STEMI with a relatively high TIMI risk score. He has triple vessel disease. He's got left ventricular failure. His CHA-MC score was very high, was 6. That gives you a 1-year stroke risk of 9.8%. His has-bled score was 3, which gives a 1-year bleeding risk of 5.8%. He's already had a past stroke with residual hemiplegia in addition to his lipids and hypertension. It was decided that he should go for PCI rather than CABG. He underwent PCI to the LAD and the OM. A trial of PCI to the RCA failed, but a repeat could be attempted. He's got a good result from the LAD and the OM. He was discharged on 2 medications, on clopidogrel 75 milligrams and apixaban, in addition to the rest of the medications. So in summary, this was a 78-year-old man with chronic atrial fibrillation who presented with non-STEMI, who was discharged on 2 medications, on clopidogrel and one of the newer anticoagulants, with a relatively high CHA-MC score 6 and a high has-bled score of 3. He also, his DAPT score was 3. Professor will be talking about the DAPT score, but in fact you can calculate this, and when you calculate a score of 3, that actually gives him a good long-term, if he doesn't have any major ischemic or bleeding event in the first year, he will benefit from prolonged dual antiplatelet therapy with reduction of events after the first year. The second case is slightly different. This is a case of an acute STEMI who had PCI and was complicated with a stroke. He was 62. He had chest pain at another hospital and was treated with thrombolytic therapy. After initial improvement, his symptoms recurred, and he was basically referred to us for rescue PCI. We found that he has an occluded LAD. Essentially, he's got some disease in the other vessels, but mainly the LAD was his major problem. Underwent an eventful procedure with a drug-eluting stent, was given intraprocedural heparin and tirofiban. On the planned day of discharge, 3 days later, he developed neurological signs, mainly nominal aphasia. On that same day, we also check the response to clopidogrel, and in that particular patient, even though he's had adequate loading, he was found to be non-responsive to clopidogrel, and this was changed to ticagrelor. His brain CT showed that he has a fresh parietal cerebral infarct, and when we repeated his echo, we found that he has an apical left ventricular thrombus, for which he was now anticoagulated with enoxaparin followed by warfarin. And he remained on actually triple therapy, including aspirin and ticagrelor. The reason why we maintained the ticagrelor was that he was not really responsive to clopidogrel, and we continued him on warfarin after the enoxaparin. He stayed on warfarin for 7 months. Repeat echo showed resolution, complete resolution of his LV thrombus, and resolution of his signs have also resolved, and he has been able to go back to full-time work. So in summary, this was a 62-year-old man who had acute STEMI and had rescue PCI and drug-eluting stent within 9 hours from symptom onset, who develops left ventricular thrombus as a complication of his acute MI, which that was also complicated with embolization and acute stroke. He was treated with dual antiplatelet therapy as well as anticoagulant with warfarin. His Hasbled score was 1, his DABT score was 3. This was, again, this I'll just spend maybe, already Professor has indicated, but there is a calculator online, and people can actually calculate the risk, and it basically incorporates age, diabetes, current smoking, previous history of myocardial infarction or intervention, presence or absence of heart failure or impaired ejection fraction, and then on this presentation, whether the patient had MI, vein graft intervention, or a stent diameter of less than 3. Depending on this, basically, if patients who have had no major bleeding or ischemic event in the first year after PCI with stenting, a score of 2 would indicate that bleeding risk may outweigh continued dual antiplatelet therapy, whereas a high score would indicate that the ischemic benefit may outweigh the bleeding risk, and that person would probably benefit from prolonged dual antiplatelet therapy. Thank you very much. That's the end of these 2 cases, and we'll be interested to hear your comments.